legislative briefing this morning. I know it's one more Zoom call or video call that you have to be on, but we'll try to make this as succinct and interactive and interesting as we can. My name is Garen Corbett. I'm the director of the California Health Benefits Review Program. We're delighted to have you and really appreciate you all making time for joining us this morning. Just a couple of housekeeping items as we get started, then we're going to do a quick poll. We will have a Q&A feature as well as the chat box. If you have any technical issues, please let us know via the chat function. If you have questions, we will have plenty of time at the end to answer them, but feel free at any point during the presentations to put in your question during the Q&A that we'll be compiling during our briefing, and we will do our best to answer all of the questions at the end. So again, thank you so much for joining us. Would love to launch a quick poll so we can get a sense of who is in our audience. And I'll pause for a moment. So we have this handy dandy interactive poll here of asking for folks who are in attendance. If you are a legislator or legislative staff, please indicate. An executive branch staff member, a staff member of health plans, an advocate, a researcher, academic, a CHBRP contributor, or a member of the general public. So we'll give you about 20 more seconds to complete that, and that gives us a great sense of who's in the audience, which is so far we see a nice mix of folks from a lot of different backgrounds. So thank you so much for making the time. We'll give it another 10 seconds. I think that's pretty good. 78% voted. So thank you all very much for doing that. So with that, I would love to hand it over. Here, we can share results. So you can see a broad mix of folks, and we really appreciate your joining us this morning. So I would like to hand it over to John Lewis, our Associate Director, to give you an overview of the California health insurance landscape. Thank you, John.
Thank you, Garen. Let's see if we can advance to the perfect slide. Thank you. In this section, I'll provide sort of a basic overview of health insurance in California. Many of you are super familiar, but we want the other folks to have some background. Briefly, I'm going to cover what is health insurance, how it's regulated in California, and how many Californians have which kind of health insurance, as well as what benefit mandates are and what kind of overlap there is between mandates in California law and mandates that are in the federal law. So the basic definition for health insurance is that it covers medically necessary tests, treatments, and services, excepting some exclusions, and it protects against some or all financial loss. It can be publicly or privately financed. Medi-Cal is a well-known public source, but the health insurance accessed by state employees through CalPERS is also publicly financed. The privately financed insurance, on the other hand, most often comes through a private employer, but it can include health insurance that a person could go out and buy directly. Next slide, please. So health insurance is regulated at the federal level and can be regulated at both the federal and the state level. It can be subject to state laws, but may not be, and that includes benefit mandates. And where there are mandates, there can be variation. Not every benefit mandate law is written to apply to as many forms of health insurance as it possibly could. Next slide, please. California is the only state with two separate regulators for health insurance. In California, the healthcare service plan contracts are subject to the California Health and Safety Code and are regulated by the Department of Managed Healthcare. Next slide, please. Meanwhile, health insurance policies are subject to the California Insurance Code and are regulated by the California Department of Insurance. Next slide, please. In order to answer the legislature's questions about how benefit bills could affect the future, each year CHBRP estimates insurance status for the year when those laws would come into effect. This document, which is on our website, offers CHBRP's latest estimates, which will be used for our upcoming analysis. Next slide, please. Here's a chart from that document. The first column represents uninsured Californians. The middle column, those are Californians, they have health insurance, but it's not subject to either of California's two regulators. Examples would include Medicare beneficiaries or persons enrolled in the self-insured plans offered by a lot of big employers. The third column represents persons enrolled in state regulated plans or policies. It's a slight majority of all Californians. And you'll notice there's a chunk of folks who are Medi-Cal beneficiaries who are enrolled in something that is regulated by one of our two state regulators. But if you look back at the middle column, you'll notice there's some other Medi-Cal folks, people who are either enrolled in one of the county organized health system managed care plans, or who are really just attached to the fee-for-service program. Next slide, please. Now, in terms of the folks who are in a state regulated plan, we often refer to these in terms of market segments. There's the large group and small group, for which employers are the most common purchasers. CalPERS is one. Though other actors can also be present. For example, some unions purchase group health insurance for their union members. The name individual market describes the purchaser, not the enrollee. So I, as an individual, I could purchase health insurance for multiple people, say myself, my spouse, and our kids. And there's also this sort of special category where we're listing Medi-Cal here. As you all know, Medi-Cal isn't for sale really in a market, but it's important to remember that enrollment in a DMHC regulated plan has been purchased for a majority of the Medi-Cal beneficiaries. In this case, the purchaser is the Department of Healthcare Services. Next slide, please. Now, benefit mandate laws. These are laws that place some sort of requirement on some or all health insurance plans or policies regarding coverage for some set of tests, treatments, or services. In this document, which is also available on CHBRP's website, there's the list of the mandates that CHBRP is aware of that are relevant to health insurance regulated by either DMHC or CDI. This is a list we use to identify a bill's possible interaction with existing mandates. Next slide, please. Our document lists 79 benefit mandates that are in California state law. It also lists the 5 federal laws that include mandates certainly applicable to DMHC or CDI regulated plans or policies. I want to focus a bit on 2 of those mandates that are in the Affordable Care Act. Those are the Federal Preventive Services mandate and the Essential Health Benefits requirement. Next slide, please. In terms of the Federal Preventive Services, and this is separate from the Essential Health Benefits requirement. Essential Health Benefits has some similar language, but this is separate. In this case, we maintain the list of the mandates that result from this Federal Preventive Services mandates references to quite a number of different sources. Next slide, please. Oops, next slide, please. Thank you. The list has 73 mandates from 4 sources, USPSTF, ACIP, and 2 different HRSA sources. We keep this list in order to be aware of possible overlap. Is the bill looking at something that is addressed by one of these? It's very helpful and might be good to look at. The document also indicates where we are aware of a state law that is overlapping or connected in some way. Next slide, please. CHBRP also maintains a resource that discusses the ACA's requirements for some health insurance to cover essential health benefits, or EHBs. Next slide, please. Where the Federal Preventive Services mandate, through those specified resources, requires coverage for particular tests, treatments, or services, the EHB mandate requires coverage for these 10 broad categories. Now, you'll notice that preventive is a category that seems well within here, but it's not being so specific as the preventive services mandate. Now, in terms of who has health insurance that must cover these broad categories listed out in the EHBs, the number may be smaller than you think. Next slide, please. The first column represents, again, California's without insurance. The middle column represents Californians whose insurance is exempt from the HB requirement. That includes everyone in the large group markets regulated by DMHC and CDI, as well as others, Medicare beneficiaries, people in self-insured programs, etc. That last column represents those who have health insurance that must cover HBs. It's most, but not all, of the people in the small group market, and a very large proportion of the folks who are in the individual market. In all, it's about 12% of Californians who have health insurance that have to cover EHBs. Next slide, please. At this point, I'll pause and turn things back over to Garen and take questions and answers at the end of all three presentations.
Thank you very much, John. This first slide here, I wanted to call out a picture of many of the faculty and staff, as well as researchers that do CHBRP's work back when we actually could meet in person. So I would love to start us off with a quick poll to get a sense of how familiar folks are with CHBRP before we tell you a bit more. Real easy, 3 options. Very familiar, I have a CHBRP t-shirt at home. Somewhat familiar, I want a t-shirt. And not familiar, hopefully by the end of today, you'll want a CHBRP t-shirt. All right, and it looks like we have a nice mix. And welcome to those of you who are brand new. Let's give it another 5 seconds or so for that. Terrific. All right. Well, again, I am still Garen Corbett. In this presentation, I'll be telling you a bit more about what CHBRP does, who we are, how we work, and what kinds of resources we have available to assist you in your health insurance related work. So what is CHBRP? First, CHBRP is an independent analytic resource that is located within the University of California system. Our offices are located on the Berkeley campus. You saw the pretty picture of the main library in our opening slide. We conduct legislative analyses on health insurance related legislation using multidisciplinary teams, who I'll discuss more on the following slide. Our charge is to provide neutral, evidence-based analyses at the request of the legislature, adhering to the fast pace of the legislature by completing our analyses within 60 days. And our work is funded through a small assessment on health plans in California. We were established back in 2002, and most recently, we were reauthorized last year. Next slide, please. CHBRP is led by a core staff of 4, with 1 current vacancy, again housed at UC Berkeley, who act as project managers and policy generalists and handle internal and external stakeholders, organize the teams, train, and so forth. CHBRP leads also write the policy context section of our reports, which we'll discuss in more depth in the next slide. We also contract with 1 or 2 contract leads who work with us during our peak legislative season. We have a wonderful task force of researchers from campuses across the University of California system who do much of the writing of our reports. This task force includes medical and public health experts, as well as economists. CHBRP also contracts with an actuarial firm who helps us do the deep dive into cost and utilization projections. We currently work with Milliman. Our analyses would also not be possible without fantastic medical librarians who help us with our literature searches to support our analyses, sometimes sifting through thousands of citations. We also employ content experts, often faculty, from within the University of California and oftentimes beyond, with very specific and expert knowledge of a given topic that supports our analyses. Our work is also reviewed by our National Advisory Council. We're fortunate enough to have, I think, at least 1 who's joined our briefing this morning. Our National Advisory Council is comprised of health experts from outside of California who review each of our reports. Because of our location within the University of California system, we're able to easily work with fantastic students who attend UCs. During the academic year, we typically employ a student assistant or two. Our current assistant is an undergraduate student of public health. And then in the summer, we work with graduate student interns pursuing graduate or doctoral degrees in public health, public policy, or related disciplines. Our 2020 interns are pictured on the slide here on the bottom left and right. One was from UCLA, Sam, and one was from UC Riverside, Niloufar. All of our contributors, whether or not students, content experts, NAC members, staff members, faculty, all adhere to a very strict conflict of interest policy to ensure that CHBRP remains a reliable, neutral source of information for the legislature. So upon receipt of the legislature's request, CHBRP instantly convenes multidisciplinary analytic teams to provide the rigorous objective analysis before the policy committee hearing. Once the legislation is introduced, typically it's the Senate and Assembly health committees that are the ones making the request for CHBRP to analyze the legislation. CHBRP most often analyzes what are called health insurance benefit mandates, which require health insurance coverage of a particular test, service, or treatment. Bills we analyze may also have to do with benefit design. For example, things that impact cost sharing or reimbursement for an expanded scope of practice by a type of provider. Bills we analyze also may have to do with cost, having impacts on cost sharing limits, such as out-of-pocket expenses, deductibles, or copays. Adara will discuss this further in her presentation. And usually within a week of CHBRP submission of our reports, the committee, typically it's one of the health committees, votes on the piece of legislation upon receipt of CHBRP's analysis. Next slide. This chart gives you a sense of the flow of activity that we initiate when working on each of our analyses. I just want to point out that this process ensures robust peer review, tons of collaboration, and reviews by senior faculty, vice chairs, our National Advisory Council, and me. Remember, while CHBRP provides quality, evidence-based analyses, we have to do this within the very tight timeline of the legislature, typically within 60 days. This is very different than other programs that are around the country that typically take a number of months and often operate between the first and second year of their legislative session. The intent of this 60-day timeline is to allow our reports to be used in real time by the legislature for its consideration. Next slide. In the next presentation, Adara will walk us through an example of a CHBRP report, but I just wanted to give you a brief framework of what our analyses include and what questions they seek to answer. In the policy context section of our analyses, we discuss whose health insurance would have to comply should the legislation in question pass, which John touched on in his presentation. We also look at what other laws in California and federal law, as well as in other states, might interact with or be similar to this proposed piece of legislation. Then we look at what the evidence says about the medical effectiveness of the test, treatment, or service that the bill would cover. We do this by doing a review of the medical evidence and making judgment calls about what the overall evidence suggests. We then examine what impacts the legislation would have on coverage, on utilization, and cost, as well as on population level health. Our reports are meant to elevate policy discussions relating to legislation dealing with health insurance. CHBRP does not provide recommendations in its reports. Rather, we present what the evidence says about medical effectiveness, public health, and cost, and leave the legislature to make its determination about what this means for the prospect of that bill. Next slide. Thank you. All of our analyses and requests are posted on our website, www.chbrp.org. Anyone may sign up for our listserv, where we keep folks updated on our work. head to our website and click on the red sign up for our mailing list button on the lower left-hand side of our homepage. CHBRP has produced almost 200 analyses, as well as numerous letters, briefs, resources, and materials, again, all available on our website. I'm pleased to say that CHBRP's work is consistently referenced by key stakeholders throughout the legislative process. It is referenced by the reviews, the committee analyses produced by Health and Appropriations Committee staff, by bill authors testifying at committee hearings, by others testifying either for or against a proposed piece of legislation, and by the governor's office for bills that complete the legislative journey. I also want to draw your attention to other resources that are available on our website. John mentioned a few of these in his presentation, including our estimates of sources of health insurance document, our issue brief on essential health benefits, and our resources on current benefit mandates and federal preventive services. We've recently published a resource on outpatient prescription drug cost sharing and one on the medical necessity determination process for covered benefits in California, which you can find under our website under other publications. And I put a handy dandy little red square to draw your attention to that. There you also find things like our reports on implementing our authorizing statutes, kind of our periodic progress report to the legislature, and archives of our quarterly newsletter. Lastly, I'd like to invite you to follow us on social media. We don't post too many cute cat and dog pictures, but we do have lots of useful information that we try to put on social media as well. We're on Facebook, Twitter, and LinkedIn. Updates about our analyses are often the most popular items, as well as other news and articles and current events related to health insurance in California. Also, we will be posting a recording of this legislative briefing on our website, so please feel free to share with colleagues. And with that, I'd like to turn it over to Adara Citron to walk us through a concrete example of one of CHBRP's 2020 analyses.
Great, thank you, Garen. So in this section, I'll review CHBRP's 2020 analysis of AB 2203, insulin cost sharing caps. This will also provide an introduction to CHBRP reports and the type of information we include. Thank you. AB 2203, insulin cost sharing caps, would have limited cost sharing for insulin prescriptions to $50 for a 30-day supply and no more than $100 per month, regardless of the type or number of prescriptions. The cap applies to copayments, coinsurance, and deductibles. What this means is that an enrollee with one insulin prescription would pay at most $50 in cost sharing, even if they hadn't met their deductible. An enrollee who has 3 prescriptions per month would at most pay $100 for all 3 prescriptions, whereas before they would pay any cost sharing for each prescription and would need to pay the full amount if they had not yet met their deductible. Approximately 10% of Californians are diagnosed with diabetes, and insulin can be used to treat all 3 types, type 1, type 2, and gestational diabetes. Insulin is necessary for the treatment of type 1 diabetes and is sometimes necessary for the treatment of type 2 and gestational diabetes. In general, insulin has become expensive for individuals living with diabetes, and therefore cost may be a barrier to insulin use for some individuals. Other identified barriers to use that are independent of cost include regimen complexity and treatment tolerability, as well as injection-related factors such as pain. Each analysis includes the key findings at the beginning of the report, which includes a summary that provides a very high-level overview of the analysis. Included in the key findings section, as well as the policy context, is how many enrollees would have health insurance subject to the bill. In the case of AB 2203, approximately 13.4 million enrollees in commercial plans and policies, as well as those with coverage through CalPERS, would have health insurance subject to the bill. The analytic team begins by defining key terms in the bill language and determining the scope of the analysis. For this analysis, the team focused on the impacts of cost sharing for insulin. A summary of the clinical practice guidelines for diabetes was summarized at the beginning of the medical effectiveness section to provide readers with an overview of what treatments are recommended. The medical effectiveness sections are structured using key questions. For this analysis, the key questions were, what are the effects of cost sharing, in other words, copayments, coinsurance, and deductible, on insulin use and adherence for patients with type 1 diabetes, type 2 diabetes, and gestational diabetes? And what are the associated effects of cost sharing for insulin on health outcomes and utilization? To answer these questions, the medical effectiveness team, with assistance from a medical librarian, conducted a thorough literature search and summarized the relevant evidence. Medical effectiveness findings are characterized based on the level and direction of the evidence. The evidence could say something is effective or not effective, and then we tell you how strong the available evidence is. The terms we use are clear and convincing, preponderance, and limited. When the evidence is inconclusive or there isn't enough evidence, insufficient, to make a call, the teams will state as much. In the case of AB 2203, the medical effectiveness team concluded, based on the available literature, that there is a limited amount of evidence that cost sharing affects insulin use and adherence in patients with diabetes, and there's insufficient evidence on the effect of cost sharing for insulin on diabetes-related health outcomes and utilization. Each main conclusion includes a graphic to visually display the evidence grade as seen here. The full report and key findings available on our website include much more detail than what I've discussed, but these are the overall findings. The benefit coverage, utilization, and cost impact section examines the differences between baseline before the legislation is enacted and post-mandate once the legislation would go into effect if passed. Among enrollees using insulin, approximately 38% have cost sharing at baseline that exceeds the limits of AB 2203. Post-mandate, 0% of enrollees would have cost sharing exceeding the cap, and this would result in a 13% increase in utilization of insulin among these enrollees. Total net annual expenditures would increase by about $2.5 million. This is due to a decrease in enrollee cost sharing and an increase in total premiums. At the enrollee level, cost sharing reductions are greatest for enrollees who have the highest out-of-pocket costs for insulin at baseline, potentially due to benefit designs such as high deductibles and high coinsurance. Enrollees with cost sharing in the top 1% at baseline would have an annual savings of more than $2,800. The public health section ties together the findings from the medical effectiveness section and the benefit coverage, utilization, and cost impact section. The reduction in cost sharing for enrollees using insulin would result in a small increase in utilization of insulin. However, there is not enough evidence to determine whether this increase in utilization of insulin would result in improved glycemic control, decrease in healthcare utilization, reduction in long-term complications due to diabetes, or improved quality of life. While some enrollees may experience changes in these outcomes, the extent is really unknown. All right, so that does it for our formal presentations. Thank you so much for joining us today. Here is our contact information if anyone would like to reach out or has questions about what we've discussed here. And as Garen mentioned, please also sign up for our mailing list, which you can do on our website, and follow us on social media. And I will turn it back over to Garen.
Thank you so much, Adara. Before we do a launch a survey and jump into Q&A, I did want to give a warm welcome to Assembly Member Marie Waldron, who has joined us, as well as to a number of CHBRP contributors. Dominique Ridley, Colin King, Jeffrey Rollman has joined us. and 2 of our NAC members, Rich Roberts and Stuart Altman. We're delighted to have you. We also noted a former CHBRP faculty member, Wade Aubrey, who is a physician researcher at UCSF, has joined us. Welcome. So we hope we were able to get through that material in a way that was reasonably easy to follow. Obviously, over Zoom isn't the same as being in person, but we encourage questions. And I think one has already jumped in. Are there any other questions or any other comments before from John? Do you have anything that you wanted to add?
I see one piece in the Q&A now. Madison Sheffield asking if we've considered asking some other categories of outcomes, such as medical effectiveness. And that is a key piece. A huge third of CHBRP's analysis is devoted to looking at the medical effectiveness of what seems to be the key tests, treatments, or services the bill would address. So this is always present in all of our analyses. In terms of equity impact, which Madison Sheffield also asks, we do try to look at the statewide population, and if we see examples of disparity, either in terms of presence of a disease or condition, we report on that. If we see evidence of disparity in treatment, or at least in terms of coverage, we can occasionally say something about that too. It is always a goal to try to address, as well as any social determinants of health that may be coming into play. Garen, are there other questions that you want to address?
Thank you, John. That was very helpful. It's a great set of questions. Thank you for that. I am not seeing any other questions, but one thing that I will mention is that during the summer months, CHBRP meets with 25 or 30 stakeholder groups, both to ask questions about how our reports are utilized and how we can continually seek to improve our work. And it's also a chance to hear how folks are using our reports and any topics that they think may be coming along the turnpike. One of the interesting parts of this role is that sometimes it's the very last minute and a bill is introduced and you just instantly turn to it. And that's been one of the fascinating parts of our work, is getting to do deep dives on a lot of different important topics. We'd love just to see, and maybe our little pop quiz will encourage, will help foster another question or two. Karen, if you could launch our quick pop quiz. All right, the first question, what populations usually have health insurance subject to bills analyzed by CHBRP? All Californians, enrollees with health insurance regulated by DMHC or CDI, or Californians whose last name include a vowel, unlike CHBRP's acronym. You don't actually have to complete I'm seeing a few people are, but health insurance benefit mandates either require coverage for a test, treatment, or service, impact terms of coverage such as cost sharing, both A and B, or determines whether health insurance is beneficial. And it looks like we're not fooling anyone with that one. CHBRP bill analyses examine the medical effectiveness, fiscal, and public health impacts of proposed legislation. How many enrollees would have health insurance subject to the bill? Remember, as John pointed out, there's areas of health insurance that are not regulated by the state, such as Medicare or ERISA plans. Existing laws related to the legislation, or all of the above. Looks like people are diving in. Thank you. And finally, the last question. Absolutely, we'll have to add a newly developed hobbies section to our website. But information on the website does not include, okay, we'll have to add our newly developed hobbies. Sadly, we don't have our hobbies on there, but there are some cute pets and kids, so we'll have to add those. All right, well, thank you all. It is clear that folks were paying attention, which we really, really appreciate. So let's give it a moment to see if there are any other questions. Otherwise, we will launch a very quick 5-question SurveyMonkey poll. It's super helpful to hear what information was useful, or perhaps you would have loved to have heard more about something else. So that survey will just give you, take about 45 seconds to complete, and we'll give you a chance to give us that important feedback. Again, this recording is available to others along with our slides that will be on the website. So if there are staffers who are suddenly in a week from now trying to figure out what is CHBRP, because they have a bill that they think will likely come to CHBRP, please point them to that resource. And of course, we are here at any time to answer questions. We have our general mailbox, as Adara had up on her slide, our email addresses. We're here to support you and answer any questions that come along. All right, let's see if there are any additional questions. So Assembly Member Waldron, does CHBRP do analyses for health plans also and for private groups? No, we are here to support the legislature. Our work is driven by the legislature. And while health plans and private groups often use our analyses because they have interest in the proposed legislation, our primary client is in fact the legislature. That's a fantastic question. Thank you. And through the work with the economist, Madison asked another great question. Through the work with the economist and actuaries, how often is it possible to include not only analyses of cost, but also of savings? We do when the evidence supports that. So there are times that we see bills with projected savings, or at least offsets. Offsets are more often something that you might not see, something that costs $10, but there are some offsets because there are improvements in health outcomes or shifts in other costs. Every now and again, we see a bill that would be not only might actually save money. It's a great question. All right. Well, I think we'll give it another few moments. Sure, Adara.
We had another question in the chat box asking about whether Medicare enrollees were subject to DMHC and CDI regulation and whether CHBRP included this population in our bill analyses.
It's a great question. Since John, you're on a roll with health insurance, you want to take it?
Medicare beneficiaries don't have DMHC or CDI regulated insurance. So the state bills that we look at do not affect their health insurance. And so they're not included because their health insurance would not be impacted.
Thank you. Great question.
Garen, I would point out too, similarly, the self-insured universe, large companies will often have available for their employees not only enrollment in a DMHC regulated plan or CDI regulated policy, they may also offer enrollment in a self-insured plan. These also are subject only to federal law. ERISA is the law that governs them, and state mandates don't hit those. It's important to remember that there is a chunk of folk who are getting their health insurance through their employer for whom their health insurance would not change due to a state level benefit mandate.
Absolutely. Thank you for that. All right. Well, I think we'll pop up the, I will click end to the webinar, but hold on for one moment for those who are attending. The survey will pop up at that point, but just would like to close by thanking you all for joining us today. Please stay safe and healthy, as Adara notes. We really appreciate your attention. Again, we're here to assist you, and take a look at our website. There's lots of useful stuff there. So again, the survey will pop up. Thank you for your attention and time this morning, and stay safe. Thank you very much.